Previously, it was believed that arthrosis of various joints is a purely degenerative disease. At some point, joint wear and tear progresses to such an extent that it ultimately requires replacement. We now understand that cartilage degeneration is triggered by chronic infection, specifically chronic inflammation. We also now know that chronic inflammation leads not only to the development of arthrosis, but also provokes the development of cancer by weakening the immune system, etc. Chronic inflammation is a very broad field of medicine that is also directly related to arthrosis. What is our body trying to do when we have chronic inflammation? Our body's recovery mechanism is based on increasing blood flow. However, when blood flow increases, certain irritants or toxins called cytokines are released. Because blood flow increases, they naturally worsen chronic inflammation. As more and more blood is needed to repair the damaged area, newly formed primitive arteries grow into it. These arteries usually do not have the typical three-layer structure of vessels with a normal barrier. Instead, they only have one extremely permeable layer. This means that all these irritants can get into the environment. In addition to these primitive vessels expanding into the area affected by chronic inflammation, primitive nerve fibers appear there as well. These are type C nerve fibers, also known as pain fibers. These pain nerve fibers do not have a normal nerve sheath. This means that they cause severe diffuse pain that is very difficult to treat with medication. Because now in the area of chronic inflammation, there is a web-like plexus of pain nerve fibers that is practically uncontrollable. It should be understood that medications have side effects and cannot provide the desired effect. As a result, chronic inflammation contributes to further progression of the pathological process, while the release of cytokines provokes cartilage tissue destruction. Previously, the most reasonable solution in such a situation was to perform arthroplasty or joint replacement surgery. Nowadays, however, many patients who have undergone this surgery still suffer from pain, and sometimes even more than before. What is done in such cases now? Doctors either continue pain management or perform repeat joint replacement surgery. Is there any benefit for patients in this case? No, they still experience pain. Is it advisable to perform this treatment? I don't think so. Therefore, if arthroplasty is not accompanied by a synovectomy, a very complex and labor-intensive surgical procedure to remove the inflamed synovial membrane of the joint, the patient will not receive the desired clinical result. In such situations, embolization plays an important role. For example, Genicular Artery Embolization, GAE. The origins of this method were laid by sports medicine specialists from Japan. The genicular artery embolization technique was developed by my highly respected colleague, Yujiro Kuno. This method has proven effective in treating pain syndromes associated with Achilles tendon ruptures and other sports injuries. The original idea was to develop a therapeutic technique that would get professional athletes back on their feet as quickly as possible so they could resume intense training and competition. Eventually, like Teflon finding its way into our kitchens, but originally intended for use in rocketry and space exploration. This technique from high-intensity sports medicine is now available to everyone, and that's great. This interventional procedure currently makes it possible to limit the progression of the inflammatory process by introducing a certain combination of drugs and embolizing microspheres into the lumen of the blood vessels, supplying the joint through vascular access. This process significantly reduces inflammation, which disappears altogether over time. We see that many of our patients have virtually no clinical symptoms after this treatment. Their swelling disappears, their mobility is restored, and their endurance improves. Notably, positive treatment results with embolization can also be seen on MRI scans, including the condition of the cartilage. One illustrative example of the procedure's effectiveness among my patients is the case of one patient who could not walk more than 30 meters on her own before this therapy. A year later, she showed me photos taken during her pain-free 7-day hike through the Alps. Of course, we all dream of such therapeutic successes. Therefore, I am absolutely convinced that if prostate artery embolization has become a significant achievement in interventional radiology, then arterial embolization for joint diseases begins a completely new chapter in the history of minimally invasive therapy and interventional medicine. Just like on the knee joint, this procedure is performed to eliminate pain in the shoulder joint, which many patients suffer from. It can also be used to treat conditions such as tennis elbow, golfer's elbow, Achilles tendon rupture, plantar fasciitis, hip pain, and many others. We are pleased to offer patients treatment using this advanced technique. By the way, it is quite interesting that progressively thinking orthopedists also recognize the great potential of embolization and refer patients to us. At this stage, I can only encourage all related specialists, including occupational therapists, physical therapists, and exercise therapists, to consider this therapeutic option when patients present with appropriate complaints. Embolization does not cause any complications, is well controlled, is performed quickly, without general anesthesia, and without bleeding. This procedure really helps the patient to get rid of pain in a minimal amount of time. The earlier embolization is performed, the better, because with early embolization, chronic inflammation is less severe, and the patient will be able to avoid serious cartilage degeneration, and therefore avoid joint replacement surgery. In earlier stages, it is possible to prevent inflammation from progressing. However, if the patient's cartilage has already begun to degenerate, it cannot be cured. Today, there's an international consensus among professional societies on this issue, and I have the honor of being a member of the 10 most reputable of them. In the advanced stages of arthrosis, when the articular cartilage is already absent, the patient is clearly indicated for joint replacement surgery. The only question is whether it is ethical, economical, and medical appropriate to observe this clinical development of the disease for decades when it is already known that it can be contained and prevented with just one embolization procedure. We discussed joint embolization at the American Professional Society meeting in May and came to the conclusion that the rate of lack of response to this treatment is 0. In other words, embolizing all the vessels that cause synovitis or inflammation of the synovial membrane of the joint will help prevent the progression of arthrosis. I confirm this based on my own clinical experience. We have been performing arterial embolization for joint diseases for 5 years now. Patients come for follow-up appointments with no symptoms or complaints. They are happy with the results. We have never had to repeat treatment on the same joint. If a patient has a problem with their second knee joint, we embolize the arteries of that knee. However, there have never been requests for repeat embolization in the same target area. The important thing is that the embolization procedure is safe and easy for interventional radiologists to perform. It is a really safe treatment. We are currently using a combination of drugs, which is the first of its kind to be recognized worldwide. In this regard, I would like to ask my colleagues in the pharmaceutical industry to consider how they can help, as this is a new form of topical drug application. It is not a case of applying an ointment and waiting for it to somehow penetrate the skin into the joint. So there is a huge potential in this area that has yet to be unlocked. We have a lot of work ahead of us that needs to be done now.